Welcome everyone to track 3. We'll go ahead and get started. Sorry for the delay with the technical difficulties. So today's track 3 for regulatory science and governance. My name's Sonu. I'm a second-year master's student here at the School of Public Health. With me, we have Gabe. Gabe, would you like to introduce yourself?
Hi everyone, I'm Gabe. I'm from Sao Paulo, Brazil. I'm pursuing my MBA at the Ross School of Business, also pursuing the healthcare concentration. And after the MBA, I'm going to McKinsey & Company.
Awesome. Thanks, Gabe. Our moderator for today will be Dr. Prashant Yadav. He is here with us and he is would you like to introduce yourself, Dr. Yadav?
Thanks, Sonu. Welcome, everyone. I think this is an important area. We can't have successful supply chains unless we can have assurance of quality of health products. So this track on regulatory science and governance is an extremely important one. My name is Prashant Yadav. I'm on the organizing committee of the Global Health Supply Chain Summit. We have 3 very interesting talks, so I don't want to take any more time, and let's get straight in, given that we've already had a few minutes delay due to technical difficulties. So over to you, Sonu.
Thank you, Dr. Yadav. So our first presentation today will be COVID-19 prophylactic and therapeutic agents supply in the sub-Saharan Africa. We'll go ahead and get that started for you. Thank you.
You all see the screen?
Yep.
Okay, I will start the presentation. Let me know if we have any.
My name is Norman Yazema. Thank you very much, Mr. Chairman, for introducing me. My topic is as projected, and allow me to wear 3 hats. For my presentation, as an academic, as a former regulator, and also someone involved in industry. So you will see perhaps some of the emphasis that I'll be making during my presentation will show you, will betray me. Let me put it that way. Thank you. Can I have the first slide, please? Let me put my presentation into context and say historically, access to new and effective prophylactic and therapeutic agents have been a major challenge in sub-Saharan African countries as they moved from colonialism to independence, with health systems providing for few and subsequently for many. And today, COVID-19 has laid bare deep inadequacies in these health systems and readiness to deal with the public health emergencies and the promotion of the One Health initiative. Significant gaps continue to exist in the pipeline and access to critical commodities such as vaccines, essential medicines, and diagnostics. And at the same time, it appears there is lack of appreciation of the principles of regulatory science and its international application. Regulatory science principles and applications are critical when it comes to access to safe, effective or efficacious quality and affordable medical products in achieving universal health. What is regulatory science? It is a range of scientific disciplines that are applied intellectually and practically to quality, safety, and efficacy assessment of medical products. These disciplines also inform regulatory decision-making throughout the life cycle of a medical product. Regulatory science encompasses basic and applied medical sciences and social sciences through observation and experiment to contribute to the development of regulatory standards and tools to systematically study the structure and behavior of the regulatory world. In other words, regulatory science can be considered as the application of the scientific method to improve the development, review, and oversight of new drugs, biologics, and devices that require regulatory approval prior to dissemination or market authorization. And regulatory science taxonomy includes preclinical evaluation of safety and efficacy, clinical trial design and analysis, post-marketing or pharmacovigilance review of safety and optimal utilization, and the healthcare policy implementation. It is not regulatory affairs. Because regulatory affairs is the application of already defined regulatory principles, and it is reactive, while regulatory science is proactive, even in supply chain management.
Sorry, there is an issue with the slide. I'll try to start the slide again.
That slide shows that there are many bottlenecks in the supply chain that people need to understand. And regulatory science can unravel some of the bottleneck problems that are faced, from raw materials to the availability or non-availability of a medical product. I think it's important to appreciate that regulatory science application has challenges in sub-Saharan Africa. So I set out to unearth the challenges that regulatory science was facing regarding prophylactic therapeutic agent supply for COVID-19. To do so, I reviewed relevant literature, including gray literature on regulatory science, by examining and reading documents such as Pharmaceutical Manufacturing Plan for Africa and the report that was written by the South African Regulatory Authority on Regulatory Science, Capacity Building in Africa, and participating in several webinars that were organized by the African Union on vaccine manufacturing, AU, CDC, several webinars held weekly for months on public health emergency operating centers, problems that they were facing. And in addition to that, participating in the European Federation of Pharmaceutical Industry Associations, and also reading documents from the European Medicines Agency and also the FDA. Let me share with you my observation from the exercise. It appears that regulatory science never was on the radar screen of these high-level meetings organized by the African Union, NEPAD, and the CDC for Africa. It's hardly surprising, because one could see there was a lack of clear understanding that translating a new idea such as COVID-19 mRNA vaccine, for example, from discovery to a medical product is a complex process, which requires the involvement of an entire ecosystem consisting of academia, industry, healthcare providers, government agencies, and the general population. And politics appears to have overrun regulatory science and science in general, resulting in COVID-19 infodemic regarding, for example, the virus itself, its prevention, transmission dynamics, and treatment. And emergency use authorization has been confused with local exemption health products regulations applied by many weak regulatory agencies in Africa. The interpretation is different in different countries. It is interesting to, to note that there are some countries in Africa that still have incomplete or incoherent legal and regulatory framework, in spite of the AU having established the African Medicines Agency. And apparently, some of these countries that have access to vaccine through COVID have entered into bilateral agreement with the vaccine suppliers. Whether this can be interpreted as vaccine diplomacy or not, I'm not so sure. And there also appears to be vaccine apartheid, particularly when an African country is able to buy the vaccine, but they've been denied access. This idea of having different suppliers of vaccines and or different vaccines in the country flies in the face of African Medicines Regulatory Harmonization Initiative, which was a precursor of AMA. And as a result, some of these countries have unused stocks of vaccines because of vaccine hesitancy or conscientious objection in their population. And they're beginning to talk about mandatory vaccination. Now, had regulatory science been applied, this would not have been the case. A lack of manpower should not be used as an excuse for poor supply planning and management or poor vaccine uptake in these countries. When it comes to other health products, a lot of countries have seen spikes in the demand for the different essential therapeutic agents, for example. And this has resulted in shortages. Some of these agents are generic medicines and nutritional supplements that are normally on their national essential drug list, unfortunately not locally manufactured. But when it comes to the issue of shortage, I think it's important that the definition of what is meant by shortage should be harmonized among all stakeholders in the supply chain. And COVID-19 has also seen a repurposing of some medicines on the essential drug list, creating an opportunity for entry of poor quality products on the African market. These have included things like ivermectin, hydrochloroquine, nutritional supplements that have been pushed as immune boosters, diagnostics that are not calibrated, oximeters, electronic thermometers, and personal protective equipment. In conclusion, I think it's only fair to say regulatory science in Africa faces many challenges which are surmountable, and these include poor understanding that translation of a new idea such as the mRNA vaccine from from discovery into medical product is a complex process, and that appreciation of the need to create a highly orchestrated network for vaccine and therapeutics agent supply management is lacking in Africa. There is no meaningful dialogue in the entire ecosystem involving many of the stakeholders involved in the supply chain. And the medical scientific knowledge regarding vaccine efficacy, viral mutation, and antimicrobial agents emerging continuously is a big challenge for regulatory science. It would be amiss of me if I did not suggest the way forward. One of the ways that could be done in order to deal with the challenges is for the regional centers of regulatory excellence to continuously capacity build regulatory sciences and aligning it with translational science. And the governments, in the meantime, can also strengthen public health emergency operation centers, which should be familiar with national vulnerability index that is developed by the national regulatory scientist. And perhaps there is need for the development of a regional procurement cooperation strategy for locally manufactured essential drugs.
Apologize for that. I'll try to run this slides again.
This present slide and the two that are following are for you to mull over. I thank you. This is what a pharmacist should look like.
Thank you for that.
Thank you. I've managed to come in. Thank you very much.
Thank you for that enlightening presentation. Since we have the presenter here, if anyone has any questions, we can facilitate those now. Feel free to unmute and speak up or put it in the chat. It looks like we have somebody who commented that they appreciated the presentation and they're looking forward to sharing the knowledge.
If there are no questions, I hope I wasn't speaking to myself.
No, I think it was a very thorough presentation, which answered all those questions. I think in the interest of time, if it's okay with you, we can move on to the next presentation, and feel free to continue to put questions in the chat if anyone has any. And will you be around to answer them, sir? Awesome. So we'll move on to the second presentation for today. Second presenter, the presenters will be Victor and Kenji, and I believe they are both here and ready to present. Kenji?
So we're here.
Awesome.
And we're ready to present. Maybe we'll have the slide projected.
Yep. Ready when you are.
Can you see the slides, Kenji?
Yeah, I can see it from the outline. Yeah.
Okay, yeah, I have them projected, so you can go ahead and start whenever and tell me to advance as the presentation goes on.
Okay, so I can go ahead.
Yep.
Okay, good evening, everyone, and thank you for the introduction, Gabe and Sonu and other colleagues that have joined on the platform. I'll be talking on alongside with my colleague. My name is Kenji Goit. I work with the National Malaria Elimination Program in Nigeria. And with me on this presentation is pharmacist Victor Adebayo. He's also a senior manager with Catholic Relief Services on supply chain management. And I'll be making a presentation I'll be starting the presentation on the topic that has been projected so far. So next slide, please. So we'll just run through the introduction, and then we'll look at some of the measures that we've taken in the face of COVID-19, and then the method we used in order to get the results that we are going to be sharing with you shortly. Next slide. So Nigeria, it's endemic with regards to malaria. And according to the World Malaria Report of 2020, it is the country with the highest prevalence and mortality of malaria. And it's accounting to about 27% of the global malaria cases, and as well as 23% of the malaria deaths that has been recorded. This goes to show us that indeed malaria case in Nigeria is something that needs to be given priority. And it's in that effect that the country itself has strengthened its strategic plan towards reducing the malaria burden by eliminating the malaria burden in Nigeria. And one of the critical elements or the channels that it using is a very high performing supply chain management system in order for it to drive this zero malaria strategy that it's one of its core goals in the strategic plan. Next slide. So the emergence of COVID-19, which led to a disruption of the global supply chain, has further exposed the flexibility as well as the resilience of the global health supply chain, among other supply chains systems that we have. And we know that the implementation of various malaria interventions being supported by the Global Fund in Nigeria was significantly affected and impeded, and also threatened in some cases as a result of the pandemic, the lockdown imposed by COVID-19 in 2020. And what this means is that, you know, there's a slogan: when there are no products, there won't be program. And so this threatened the implementation of a lot of these interventions, the various interventions that we have that are being supported by Global Fund in Nigeria. Then we have two major principal recipients that are implementing these malaria programs. The Global Fund Malaria Program in Nigeria. We have the National Malaria Elimination Program, where I work, and then the Catholic Relief Services, where my co-presenter, Victor Adebayo, work. And here we are supporting 13 out of the 36 plus 1 states that we have in Nigeria. And these settings were they are the high burden malaria states that we have in Nigeria, and graciously Global Fund is supporting those high burden malaria states in the country. Next slide. And so the Catholic Relief Services and then National Malaria, in collaboration with the Global Fund country teams that supports the implementation of activities in Nigeria, try to, you know, minimize the negative impact that COVID-19 has imposed on the availability of key malaria health products, and also the supply of those key malaria health products in country. And so they try to develop some mitigation measures to ensure that these products will not be completely not available within the country. So the measures are just geared towards minimizing the already negative impact that COVID-19 lockdown has imposed in the country, which I said earlier. And some of these measures were categorized as short-term measures. We have also the medium-term measures, and we have the long-term measures. Next slide. So The short-term measures are just measures that were just done for within 0 to 3 months during the lockdown, and all were geared towards enhancing the coordination of supply chain activities among the malaria stakeholders, both in country and outside the country. And what was done practically there was to ensure that there were various meetings taking place, and then, looking at the entire pipeline, looking at the availability of the commodities in country with the disruption of the influx of commodities from the international scene. And then where these commodities are high in some facilities, another short measure that was introduced was more like the intrastate redistribution of commodities from facilities that have low, they were at risk of stock out from facilities that have excess commodities to facilities that are at risk of stock out. So we redistribute them based on the daily coordination and weekly coordination activities that we have in country. Then we also have the medium term. Medium term has to do with activities that enhance the forecasting and supply chain, supply planning that within the country. For forecasting, we try to have a HMIS, that is a service data, and LMIS, which is the utilization of consumption data triangulation, to a kind of boost the accuracy of our forecasting, which we do biannually. So during this lockdown, we try to kind of activate those processes as medium-term interventions to mitigate the negative effect of COVID-19 on the supply chain of malaria commodities in the country. Then we also look at the ABC categorization of health facilities. What we did here was that we tried to categorize the health facilities based on their disease burden, so that that will inform the resupply method and the frequency of resupply of these commodities, as well as prioritization of the facilities with high burden or high disease cases, where they will be prioritized and then be given more of the commodities than the C categories that have less than 500 cases per month. So we look at the case burden and to categorize these facilities. So these are some of the measures that we have taken to kind of minimize the supply chain negative effect that we had. But my colleague, Victor Adebayo, will take on from here and then take us through the methodology, how we carry out the entire measures, and then the findings, as well as the conclusion of this presentation. Over to you, Victor Adebayo.
Okay, so like I was saying, that we conducted an interrupted time series analysis, which enabled us to determine the effect of the interventions that my colleague had mentioned earlier. These interventions included the short-term, the medium-term, and the long-term interventions that he had mentioned in the earlier presentation. Apparently, with this time series, we collected data between the period of January 2018 and June 2021, which covers a period of 42 months. And we determined the impact of these interventions that my colleague had mentioned by looking at how these interventions had helped to improve our supply chain management and reduce or minimize the impact of COVID-19. We collected data from purchase order analysis for procurement of health products that were made. And of course, we also collected data from bi-monthly facility stock reports at the health facilities. Next slide. So we focused on two outcome variables, i.e. the lead time, which is focused on the upstream supply chain activities, and of course, the proportion of health facilities with no stock out of the anti-malarials and the test kits lasting more than 7 days collected on bi-monthly basis for downstream supply chain activities. So what we did was to segment these variables, and we segmented them and compared them with the mitigation interventions that we provided. And comparing this, we were able to see the impacts of the interventions over the slopes of regression lines that were plotted in the analysis. And then, of course, by doing so, we compared the relationship between the pre and post intervention period using the statistical analysis of SPSS software. Next slide. So in terms of results, we observed that our order planning and delivery lead time, pre and post intervention, with the intervention period, we were able to achieve a reduction of the order planning lead time, which takes care of the period between when we place requisition to when the health product is delivered in country. And of course, the delivery lead time takes care of the period when we order when the products are being pre-packed and then they are delivered to the last mile at the health facilities. So in terms of our order planning, we were able to intervene, and we had a reduction of 0.65 months for order planning. And of course, we had 1.52 months for delivery lead time. Efforts that were focused on helping us to achieve this were basically collaborative effort between the Global Fund country team, CRS and MEP. We meet and we were able to strategically resolve bottlenecks, some of which were both upstream and downstreams. For example, global shortage of containers that affected shipments of some of these health products. We were able to, through those collaborative meetings, address these shortages by prioritizing some containers through strategic framework agreement with the suppliers to be able to get the health products into the country. Next slide. So in terms of downstream activities, our support covered about 8,800 health facilities, and we were able to conduct an intrastate redistribution of health products. Apparently, because of the challenges of COVID, we were not able to bring in health products as early as possible into the country. And so we had to do what is called a rationing, where we had to redistribute available health products between the health facilities. And like my colleague had mentioned, we focused on the high burden, high impact health facilities. So by so doing, we were able to reduce stock out rates by about 15.38% during the period of the peak of COVID-19. You will see that from the charts, in 2019, we did have a reduction in the terms of stock availability because of the challenges of disparity between our service data and consumption data. However, we started having an upward trend up until when COVID came in, and we had a downward trend in 2020. But post the intervention through our intrastate redistribution, we started picking up again, and we've had consistent availability of health products above the minimum range up until 2021. Next slide. All right, so in conclusion, what this exercise has taught us is that COVID-19 definitely has negative impact, apparently because of the impact that we have observed in terms of elongation of our lead time, and of course, affecting availability of health products from port of country of origin up until delivery at the health facilities in country in Nigeria. However, results have showed us that with our short-term supply chain mitigation measures, i.e. the strategic coordination of supply chain activities, and of course, with our intrastate redistribution that were conducted, we were able to significantly reduce lead time and increase proportion of health facilities without stockouts. And from the lessons learned we have, we can confidently say that we are able to, in a strategic position, make better decisions in terms of our medium and long-term mitigation measures. This makes us very much readily accessible to be able to make our supply chain resilient, and obviously we are better prepared to address future impact of any future force majeure, such as COVID-19 and any other future crisis that may besiege our supply chain as a country. Thank you for your attention.
Thank you, Kenji and Victor, for that presentation. Does anyone have any questions that we can help facilitate? I had a question, but your thorough presentation actually answered it at the very end, so thank you. In the interest of time, then, because we're already running a little behind. Oh, looks like we have a question. Daniel? How did you determine what facilities were high impact or high burden and what parameters were used? Victor or Kenji?
Yeah, so let me just...
Okay.
So let me just answer the question. This is Victor. So thank you, Daniel, for that question. Like we had mentioned, what we were able to do is to look at the number of, I did mention earlier, we was covering about approximately 8,800 health facilities. So what we did was to look at the case burden of those facilities in terms of malaria cases that these facilities attend to. What we will call a service data, which shows the patient load in those health facilities that are malaria related. So we look at it over a trend of about a year, and we were able to estimate the number of the cases. So that was what we did, and we were able to determine this. So what we did was look at our facilities in A category, our facilities that have over 1,000 cases of malaria in a month, and then those that are within the 500 to 999, we categorize them as B facilities, and then those that have 0 to, of course, they won't be 0, but 1 to 499 cases categorized as our C facilities. Thank you.
Thanks, Victor, and thank you for your question, Daniel. If we don't have any more questions, we'll get started with the third presentation by Derek Treatman.
Hello, great, thanks. And big thanks to the organizers and the other presenters in today's track, and also everyone else who's joining us today to listen in. My name is Derek Treatman. I'm a senior director at VitalWave. I've been working in the digital for development space for the past 15 years, implementing health information systems at national scale in a variety of different contexts, mostly sub-Saharan Africa and also in Southeast Asia. Today, I will be introducing the Verification and Traceability Initiative and its plans to introduce tools to prevent fraud and diversion of health products, including COVID-19 vaccines, starting next year. If you don't mind moving on to the next slide, please. I'm going to share just a brief overview of the initiative, its design for global verification tools, including a global repository of trusted health product information, how the initiative is engaging national regulatory authorities, manufacturers, and other partners, and what data will be shared and used to prevent fraud and diversion, and how to get involved. Next slide. This initiative is driven by an urgent need and demand from national regulatory authorities and ministries of health to address the upsurge in production and distribution of falsified and substandard health products. This includes COVID-19 vaccines, as well as malaria products, antiretrovirals, and other health products, which obviously introduce both serious risks to patient safety, as well as trust in public health institutions. It also costs countries quite a lot of money, over $200 billion lost through fraud and diversion last year globally. So national regulatory authorities and ministries of health, as well as partners of the COVAX facility, which is procuring and donating COVID vaccines to many countries, identified this need to prevent fraud and diverted COVID-19 vaccines. And this initiative has come together to answer that particular call, as well as the same risk for other health products. Next slide, please. So the goal of the initiative is to address both that short-term risk that I just described of falsified products, while also setting the stage for national traceability systems in the long term. We're focusing on three different initiatives or three different aspects. One is a technology itself, a verification tool, as well as other guiding materials on policies and processes that can help manage the risk of falsification and diversion. The second is that global database of trusted health product information, starting with COVID-19 vaccine information that I mentioned, that can be used to verify health products once they've arrived in country and when they're being shipped and distributed in country. And then thirdly, direct support to help to country leaders to help advocate for and implement standards-based traceability systems. And I'm speaking here specifically about the GS1 standard for supply chain systems. You see some logos at the bottom. Partners of the initiative include Gavi, UNICEF, USAID, the Global Fund, the World Bank, Bill and Melinda Gates Foundation, Digital Square, and my organization, Vital Wave. And all of these organizations are working together to both invest in these tools and those three objectives. And additionally, we have a global steering committee. We do have representatives, the director generals of the Nigerian regulatory authority, NAFDAC, as well as the Rwandan FDA that form our global steering committee to guide this work into next year. Next slide, please. I'll describe for a moment here the design of the verification tools. They are based on GS1 standards, which means they're compatible and can be integrated with other GS1 compliant digital systems for supply chain. It also means that they're scalable. So we're starting with the use case of COVID-19 vaccines, but these verification tools can store and verify any types of health product that is coded using that GS1 standard. It also means that these tools can be used to support a whole range of functions defined by GS1 for electronic product code information services, or EPCIS, from verification to different traceability applications. You can see in the diagram in the middle at the top, manufacturers. So manufacturers are the first step in verification traceability. They create products and the design of this initiative and these solutions is that manufacturers upload their batch and serialized health product information directly into the global repository using that standardized format. And that creates a trusted digital representation of every health product those manufacturers have created and have distributed. And countries and the various supply chain partners can access and verify health products, physical products, in three different ways. So the first, labeled A on the left, is through a generic mobile application which will be produced by the same technology service provider that's producing that global repository at top. So the generic application is designed to be super simple. It can be downloaded and used on regular smartphones. There's no need for any additional servers or infrastructure to be set up in country to use that generic application. You can simply scan a product code using the mobile phone camera and then verify that code against the global database. The second mode of use, labeled B, is through the integration with an existing national system. So the global repository itself will have an API as well as a mobile software development kit that will allow national systems to integrate that verification capability into their systems and send verification requests to the global repository and get a response back. The third is similar. That's labeled C on the right-hand side, and that is the ability for national systems to directly download health product information into their national systems. When a shipment arrives at customs in the port of entry of a country, its shipping container can be scanned or batch numbers can be scanned. Those can be verified, and then the global repository can allow that country to download all of the serialized health product information into their national systems, which can then be used for subsequent verification and traceability functions. Next slide, please. I wanted to mention quickly about data generation and sharing. In this design, there are two different generators of data, the manufacturers that we talked about already, and then the users, those people who are scanning barcodes or product codes. They might be immunization health professionals. They could also be supply chain partners who are scanning products as they're getting distributed. Every time a product is scanned, those users generate event data that captures the pack information, their location, the date and time that the scan took place, and other metadata about the user and their role. When we combine all this information together and look at it at a global level, this allows analysis of trends and the identification of potential suspect activity. For example, if a pack is scanned once in one country and then gets scanned again in a different country later that day, then that's evidence that perhaps one of those packs is either fraudulent or that a pack has been stolen and diverted to elsewhere. These trends can generate alerts about suspect activity that can be investigated further by the manufacturers as well as national regulatory authorities to identify possible fraud and diversion. They can involve police and other authorities that might be able to pursue and investigate those suspect activity. I'd like to note here that this type of global repository for an analysis of event data for the detection of fraud and diversion has never been done before in public health. It has been done for other types of consumer-based products. This is a major milestone for countries and global partners that are focused on traceability. And this is a first application where the trust of all of the partners involved in sharing and using these data is absolutely critical. Next slide, please. I'll just briefly mention here, because I know we're over time, that there are multiple different users who might access data for different reasons. Those users are presented here, including national regulatory authorities who might be responsible for responding to suspect activity, supply chain partners who might be responsible for investigating any events that are suspect activity, and healthcare professionals who are responsible for scanning packs and verifying them as part of their distribution and dispensation process. Next slide, please. I'll wrap things up in the next two slides with noting that, and I think this was mentioned on one of the earlier presentations, stakeholders across the spectrum in every country, from manufacturers and donors who are helping develop products and procure products, to the national regulatory authorities, supply chain partners, healthcare providers, both in the public and private sector. All of these stakeholders need to be involved and need to work together in order to achieve the success of both short-term goals that are focused on verifying products, and as well as the long-term goals for end-to-end traceability for all health products. And by applying the GS1 standard to establish these tools, we're working with countries to set that stage to ensure that the tools can be used not just for COVID-19 vaccines, but for any health product, including malaria, RDTs, ARVs, TB meds, and other health commodities. So a first step for any country on their journey toward traceability is to engage all of the different actors that you see on this slide and start active discussions on national strategies for supply chain visibility, verification, and traceability. I do want to note that you can find some really excellent guidance on those steps, establishing national steering committees and strategies for traceability from the USAID Global Health Supply Chain Program. The address for that is ghsupplychain.org/global standards. I'll paste that in the chat for folks as well. And I'll end with my next slide here. Just noting that in addition to the resources that I just mentioned, there are many different mechanisms that countries can currently tap into to obtain support through short-term COVID-19 response support mechanisms like those mentioned by Gavi, USAID, and Global Fund, as well as some of the longer-term funding and support on health system strengthening and supply chain strengthening through other global development partners. So for those of you who are interested in learning more about this initiative or generally about verification and traceability, I would like to encourage you to reach out to development partners that are active in your countries and let them know that verification and traceability is a priority for you. There's also a contact address on the next slide that you can reach me and my organization VitalWave. That's at traceability@vitalwave.com if you'd like to connect with us directly. Thank you so much for the opportunity to present and for your attention today.
Thank you, Derek. That was a great presentation, very thorough.
We do have some questions in the chat. Also some congratulations from Judith, a great presentation. From Stanley, we have how many countries have committed and started to implement this initiative and how many are targeted? That's his first question.
Great. Thanks, Stanley, very much for the questions. How many countries have committed and have started to implement? So we are working directly with Rwanda and Nigeria as part of the steering committee to plan implementations. We're also speaking with 4 other countries. I don't know if I can mention the names of those countries right now, who are interested and starting discussions with the partners, their country partners and their development partners about planning an intervention sometime next year. And that is partially the answer to your second question. What are the bottlenecks that you're facing in implementing or planning to implement this initiative? So I'll mention one, and that was discussed on one of my slides, bringing together all of the stakeholders that you have in country, including your immunization program, your Ministry of Health, your regulatory authority, your central medical stores, and all of the different supply chain partners that might be supporting initiatives in malaria or HIV or COVID-19 response. These are a lot of organizations, and they all have unique objectives and specific funding that's tied to the work that they're doing. That funding can also have various different timescales. So some might be ending or starting at different periods of time. So bringing all of those partners together and coordinating on an activity that focuses on verification of any health product, traceability of any health product is challenging. And that is definitely a major bottleneck getting people to the table and creating a collaborative roadmap on how to achieve a traceability program with all of those different objectives that need to be considered.
Thank you. And yeah, you had a second question. I think you answered it, right? Yeah, cool. Thank you. If there's any more questions, we'll take them now. And if not, a huge thank you to all of our presenters and our moderator, Dr. Yadav. And thank you to my co-moderator, Gabe. We really appreciated all of your effort. Thank you to our participants for listening in. There is a networking session following the end of this session, and it has been extended to 2 p.m. because of the delay throughout the day. So we highly recommend that you go there and connect with the rest of the presenters. And this concludes the track for day 1, and we look forward to seeing you again tomorrow and the next day. Thanks, Eric. Thank you all.
Thank you. Take care.
We'll stick around if there's any questions, but have a great day.